like to introduce Dr. Beth McNally, and she can tell us more about her clinical experience and expertise, if you would.
Yeah, so I'm a cardiologist by training, and I've worked across neuromuscular diseases for the better part of, I think, about 3 decades now, so quite a long time. I actually did all my postdoctoral training in the laboratory of Louis Kunkel, who discovered the dystrophin gene. So again, I've had a very long interest in the crossover between why some mutations affect muscle and why some mutations affect the heart. And it's how I got interested in doing all the genetics, because I would get sent lots of neuromuscular patients by the neurologists, and I would always say, well, I don't know what's going to happen to their heart until I know what their mutation is. And so once we were able to get more DNA sequencing, that's become a lot easier. Not always crystal clear, as we were just hearing. I'm just going to go through a few slides to talk about what we know about Titin and the heart, and then okay, and then is that better?
Yes.
And then we can open it up, and at any time along the way you want to ask questions, just go ahead and do that. So I always have to feel like I have to tell you this. I actually consult for a genetic testing company, which is Invitae. So if I say things around Invitae, you should be aware of that. So Titin truncating variants, we heard a little bit about this in the last session. They're the things we can interpret most readily because they're premature stop signs in this big long gene. And I think when we see 2 Titin truncating variants, one on each copy of the gene, that's what we understand best. That's easiest to interpret in the children who typically show up with skeletal involvement, skeletal myopathies. But what's really important to realize is a lot of the time, those came from one from each parent, and then that means parents are potentially at risk for what we see with Titin truncating variants when you have 1 copy. So it's really important genetics. Now, the reason why I'm hedging just a little bit around that is every now and then, it's a brand new mutation that's shown up in the child, and then that completely changes things, because we know brand new mutations, certainly in my experience, I've seen a lot of those can have skeletal phenotypes, skeletal muscle phenotypes, but then even in the next generation, that skeletal phenotype can get a little milder. So that's one of the variations that we see going on. So generally, if you're a heterozygous carrier, meaning 1 copy of a Titin truncating variant, the risk is mainly to the heart. Now that doesn't mean there aren't some that can also affect skeletal muscle, or that skeletal muscle is mild. You know, the involvement there is mild, and so it's always important to realize that. And I think as we go through this genetics, it's also really, really important to recognize what's present and how much have we actually, because sometimes there is disease there and people haven't really looked for it. So that's the other part, which is to be knowledgeable and don't be afraid to tell your physician some of the things to look for. We were actually the first to describe Titin truncating variants in the general population in 2012. So in 2012 was the first real database we had of human genetic variation. So that's not that long ago. So recognize how new this field really is. But that was the first 1,000 genomes that got published. And one of the things we did when we looked at it was we said, wow, about 3 to 5% of the population actually has a premature truncation. Now, it's realistically probably about 2 to 3% because some of the variants fall in parts of the gene that we don't really think can cause disease. And then in that same year was when Cricket-Seidman, who's the senior author on this, identified that about 20% of dilated cardiomyopathy, so when the heart becomes enlarged and doesn't function very well, is actually due to Titin truncating variants. And so about 2% in the general population, and about 20% in dilated cardiomyopathy. So you see an enrichment there that happens. So important to know a little bit about how muscle works. Hopefully you guys have heard a little bit about this. This is the unit of contraction right here. And Titin spans from this end, these Z bands, to the middle, to the M band. And the reason why is because if your truncation falls here in the I band, some of the testing companies are going to call that a variant of uncertain significance. Whereas if your truncation falls all the way down here in this end of the gene, the A band, they're going to call that likely pathogenic. I think that will change over time because a new paper just came out that suggests that really probably they all have some risk with them, but that risk is variable. So again, get familiar with the big long length of Titin. So the beginning part of it anchors here in the Z band, and the end part of it is here in the M band. So one Titin molecule goes from here to here. And so again, if you have truncations that affect the end of it, the 3' end of it, or in the A band, anywhere kind of along here, that's what people think may be more pathogenic than the ones in the I band. But again, I think that's still very much emerging data, but be aware that the genetic testing companies are taking that into account. The reason why they do that is because this paper came out in 2015. And what all these little lines across here are, if you look across healthy volunteers, this is where their truncations fall. So again, here's the front end, here's the other end, the far end, and you see that most of these in healthy volunteers tend to be on this side of Titin. And then if we look across populations, we see it's all along Titin. You can have premature stop signs. If we look at those who have dilated cardiomyopathy, you see overall it tends to be a little bit at this end of the gene. And so that's the reason for saying that. It doesn't mean you can't occasionally have a premature stop sign here, because you do see some people that do have it. But nonetheless, certain testing laboratories, when they give you your result back, they may call it variant of uncertain significance just based on where it falls. And what you're hearing me say is I disagree with that interpretation. So I will tell Invitae all the time I disagree with that interpretation, but that's how they do it based on this paper. So in other words, I'm saying they're wrong. So what has come out is that it's a little more clear that there actually is, what we understand is that there's a lot of variability, and sometimes the amount of cardiomyopathy that's present is actually really, really mild. In fact, most of the families that I follow, I may see the first person that had a Titin truncating variant, they may have worse disease, but when we go look at all their family members, most of what we see is really quite mild. We measure this by ejection fraction. Ejection fraction's normal is 55%, roughly, 55, maybe 60%. A lot of Titin carriers that I follow, it's just sitting at like 50%, maybe 45 to 50%. That's something you're not really gonna feel, you're gonna do okay with that, but we may wanna put you on some medications with the goal that we really want to keep things functioning really good for as long as we possibly can, preferably through one's entire lifespan. This is a paper that came out more recently, and now that we're opening it up a little bit more and saying, well, what do we really see associated with Titin truncating variants? It turns out we actually see atrial fibrillation, which is when the top chambers of the heart don't beat normally. And atrial fibrillation is actually a risk for stroke. And again, this is a very age-dependent penetrance, so people, as they get a little bit older, we're more likely to see this. Now, the caveat is atrial fibrillation becomes very common when we look at people who are in their 80s. It's somewhere between 8 to 10% of the population actually has atrial fibrillation by the time you get to your 80s, so it's definitely a big problem. But for people who carry Titin truncating variants, that may happen a little bit earlier. And so this is one of the things that if you are a carrier, to just be aware of. If you have symptoms of palpitations or something along those lines, this is why we monitor patients. We have you wear a Holter monitor. I think in the future, people will be wearing more of these watches because they've got some ability to detect it. And the key thing is if you're having atrial fibrillation, that increases your risk for stroke. So you want to be sure that you've had a discussion with your doctor about monitoring for this, and then potentially actually being on a little bit of blood thinner if that's in fact going on and we see presence of that. So you actually have to monitor for this to know whether it's there, because some people don't have symptoms from it. So this is sort of the high-level take-home point. Titin truncating variants, so the TVs, not all carriers will develop heart problems. We just had a discussion around that. We call that variable expressivity. Sometimes you hear the term variable penetrance. Penetrance means like in your whole lifetime you will never ever develop disease. What we really know about this is that it's variable expressivity. It's different how it expresses itself in each person. And we think that that has to do with everything from what else is going on in your Titin gene to what else is going on in all your other genes, to how high your blood pressure is, to what kind of stressors you've had on your heart. We know women can sometimes show up during pregnancy with what's called peripartum cardiomyopathy. We know pregnancy is a bit of a stress on the heart. Many people would feel like the stress is really after you have your kids, but physically it's a stress during pregnancy. And so we also know that it responds really, really well to medications, and that people can do really quite fine with this with sometimes just a very small amount of medication. So if you are a carrier, your heart problems are more likely to occur with age. This is mostly a problem for when you get into later life, and I say that with a very broad generalization because some people can have it earlier, some people may never have it in their lifespan, but it means you should monitor and look for it. So I usually recommend getting an echo every 2 to 5 years, and that depends on what that first echo looks like. If you do an echocardiogram and it just shows a little bit of abnormality, I probably would do it a little more frequently, meaning every other year, maybe even every year if it really looks abnormal. Cardiac MRIs are a much more sensitive test in many ways. That will depend where you live and how readily your insurance coverage will pay for that. I found when I write Titin truncating variant in the reason why I want to do a cardiac MRI, I almost always, here in Illinois, I almost always get that approved. I never have to call and request an approval for that. What the MRI gives us is more data on the consistency of the heart muscle itself. It tells us whether scar is present there, and the presence of scar may portend an increased risk for irregular heart rhythms. And so it just gives us more information. We're much more likely to treat you with some medications if, in fact, there is some scar present in the heart. And you don't need to do a cardiac MRI every single year, at least in my practice. I don't do it every year. I do that every couple of years. I think the major take-home point if you are a Titin truncating variant carrier is to manage your blood pressure well. I can't emphasize that enough. Right now, the American Heart Association is classifying hypertension in 5 stages, and there's what's called stage 1, which is when your blood pressure is 120, above 120 but below 130, and then in the 80s for the bottom number. And right now, the recommendation from the American Heart Association is that we don't necessarily treat stage 1 hypertension. We, in fact, manage it with lifestyle changes like exercise and watching your salt intake. And I think this is one of those situations where if I am a Titin truncating variant carrier, I'm going to have a lower threshold for what blood pressure I'm going to treat. What we know is lower blood pressure is actually going to be less wall stress on the heart. And in my experience, all the families I follow, if you happen to be put on blood pressure medications earlier in life, those are the people that do really well. And I look at them in their 60s and 70s and their hearts look great. So, and the preference for me for treating blood pressure is using things called ACE inhibitors or ARBs or beta blockers because we know those are more protective for the heart. And then to be aware of your potential symptoms, because a lot of times people don't have any symptoms. Now, obviously, if you have short of breath and swelling, you're going to get into your doctor. You're going to get seen right away. But more subtle things, like if you have palpitations, feeling irregular heartbeats, feeling your heart skipping a lot, you want to have a heart monitor. And they're very easy to do these days. They're really easy heart monitors to do. If you have fainting episodes, what we call syncope or fainting, you should share that with your doctor. You should definitely wear a heart monitor. And take care of your heart. You want to manage your cholesterol. You want to do all the common sense things we know are good for your heart. You want to have good cholesterol. You do not want to smoke. And then what I put regular with an asterisk by it, exercise. Now, my genetic counselor with whom I've worked for many, many years has heard me on this soapbox. I actually think very intense levels of exercise are potentially damaging to the heart. And what I mean by very intense levels are running marathons. I'm not a big fan of people running marathons. And the reason why is because if I take all comers at the marathon and I measure what's in their blood the next day, I see a lot of creatine kinase. I see a lot of breakdown products of both muscle and heart. And then I think of all the months of training that went into that and all the potential damage that people were doing. So I do think that extreme levels of exercise are not particularly healthy. And I would say that to pretty much anyone. I say that to all my relatives who run marathons and they never listen to me. But I will say that if you're Titin truncating variant and your heart's a little on the large size, I wouldn't take up marathon running. Instead, I would do a diversity of activities. So that's riding bikes, swimming, some running, all sorts of different things, but just mix it up and do different activities. Question? Okay, I'm getting a little feedback, so I'm trying to be careful with that. So I think those are really the high-level things. I just had, how to get genetic testing, because I know someone had asked that question. So there's 2 kinds of main testing that you do, which is site-specific. Site-specific means you're just getting the test for the Titin truncating variant that's running, or whatever the mutation is that runs in your family. So that's one change they're looking for. You can do it off spit, you can do it off blood. You can have a kit sent to your house and send it into the laboratory to get the testing done, but it does need your doctor's approval. This can be done through a genetic counselor who then would put your doctor's name on it. But you need to know the exact mutation that runs in your family in order to have it tested for that. And that can be a little bit complicated because sometimes Titan's so big that sometimes the numbering can be a little confusing from one laboratory to the next. But your genetic counselor should be able to help with that. Gene panel testing is what we do when we don't know the mutation in your family, and you can get a whole bunch of genes sequenced at the same time. The test can go anywhere from 50 to 150 genes, and both the skeletal myopathy panels and the cardiomyopathy panels all include Titin on it. If you have an I-band mutation, they may call that a variant of uncertain significance. You heard me say I don't necessarily agree with that interpretation. A-band mutations are usually called likely pathogenic, and the cost for doing that is as low as $250 out of pocket, depending which laboratory you use. It can cost much more than that, and some of the companies will actually do some investigation with your insurance company to make sure it's going to be paid for. The site-specific, right now, GeneDx is offering a site-specific for just $99, which is a really affordable price. And then when you think about this, do not be surprised if your doctor has no idea what this is about. That's pretty common. And so if you don't know that, you heard in the last session, you're hearing from me now, you know, if you can't find a counselor, email any of us. We're all available. We'll point you to a counselor in your area. We'll help you out and get that done. So it's actually very easy to do. Again, it can be done off saliva kits and blood kits, so it's very, very easy. This is just an example of what a genetic test looks like, and I'm not making this up, but this was a guy who emailed me overnight, like 2 o'clock in the morning. He sent this email. I got this test back. What do you think this means? So, and what's interesting is he actually has skeletal myopathy in his family, so it's an interesting one. But you see that this is a typical test report where here's a Titin. Here's what, with this little star here, means the premature stop sign, so this is a Titin truncating variant. He's actually got it homozygous, which explains why there's skeletal muscle disease in his family. And his email to me, he was emailing from Pakistan, and he said, my siblings have this, and you know, my parents are related, so we understand this. And so we now know that's the cause of their disease, and their hearts need to be looked after. And then this is just a variant of uncertain significance, which can also be playing a role in making disease more severe, but we know much less about that. And then a couple of just very recent papers that came out. This is a paper that came out in Circulation, I think last week or the week before. And this is saying what happens when we take a whole bunch of people who have Titin truncating variants, and then we look in their medical record, what kinds of things do we actually find? I won't go through all this. That's a complicated point. But this is all the diagnoses that were in there. So you see cardiomyopathy, but you also see premature beats, tachycardia, atrial fibrillation, heart failure. So all sorts of things that can happen. So just one last thing I want to say is this. So the huge complication with Titin, giant gene made up of lots and lots of exons, 360 exons, the pieces that come together to make Titin. And the problem is when you make a single Titin molecule, you don't always put all 360 exons into it. And that's what this data is actually looking at, which is like how often do you actually include parts of Titin in it. So you see like this dark colored here, that says almost all the RNAs of Titin have this part in it. But if you look in this middle part, there's lots that are not, lots of areas of the gene that are not included. The other complexity in doing this is that amount of splicing actually changes. For example, when heart failure starts to develop, as the heart dilates and develops failure, it now starts including and excluding different exons. So if your mutation happens to fall in one of these exons that's sometimes included in the final product and sometimes not, this is another reason why we see differences developing over time. We know that the splicing is probably not the same from person to person. It's probably not the same in one part of your heart as in another part of your heart. So this is the real complexity of this gene. So I think I'll just stop there and let you guys ask questions. So thank you so much.
Have you had any questions or comments that you want to share?
So obviously you mentioned that there are a couple of different types of arrhythmias and things that can be caused. I was just wondering, as far as low blood pressure, is that something you find in patients with cardiac issues with Titin truncating genes?
Okay, great. So low blood pressure is, you know, I have to say, I do a lot of neuromuscular patients, and I do see a lot of people with low blood pressure who have neuromuscular disease. We don't think of it as being primarily due to the mutation. There may be some mutations where that happens, some genes, but we don't specifically think of it. Honestly, I actually think of low blood pressure as being protective if you carry a Titin truncating variant. I actually think it's probably a good thing long term because you're putting less stress on the heart. The hard part is if the heart does show some decreased function and we want to put you on some of those medications that we like to use, they lower blood pressure even further. So then we end up using very small doses and figuring out the right time of day, encouraging you to stay really well hydrated so that you don't get dried out and lower blood pressure further. So it can be a little tricky to manage the medications on somebody who has low blood pressure.
Question?
Hi. Sorry. So for a family or a person who has a family history of a Titin mutation, and if they are underinsured or uninsured, a cardiac MRI is definitely cost prohibitive. An echo might be cost prohibitive, and going to a cardiologist might also be not possible. So for those, and then maybe they can do the diagnostic testing for $99 or not. But for somebody in that situation where they can't go see the cardiologist, they can't get a good assessment of the heart, what steps what would you recommend for them to talk with their primary care provider or with a health clinic or something to help try to take steps to protect their heart?
Yeah, so I do think it's really important to at least have a look at the heart using, and in this country, most of the time in the United States, we use echo. In Europe, they're much more likely to use MRI, particularly in Germany and parts, just MRIs are much more readily available. I will say, I deal a lot with Medicaid and things like that. We actually, if you put that in the rationale for the diagnosis, we usually don't have trouble getting it paid for. Now, if you're in a plan that has a really high out-of-pocket, that's what gets prohibitive. But I would really stress on at least getting an echo at some point. And then depending what it looks like, if it looks really normal, you can space yourself out every 5 years maybe, just paying attention to symptoms. Managing blood pressure, underline that, just so many ways. Just manage blood pressure, really make sure blood pressure is under good control. And if it's running at all high, even in the 120s and 80s on the diastolic, I would probably be on an ACE inhibitor or even a little bit of beta blocker. And those are very affordable medicines. They're available as generics, so that's reasonable. But I do feel like a primary care doctor can actually manage this. I don't think it requires going to a cardiologist. There's enough in the literature right now, and if you arm yourself with information and go to the primary care doctor and say, here's my risks, here's what I think I should have an echo once every 5 years, and here's what my blood pressure is. You can get a cuff and measure it at home and know what your blood pressure is run. I think that's, you and your doctor can do that together.
Is there any specific paper that clearly states how you manage blood pressure in these patients that you can recommend for them to have and show
No,
to their
it's not out yet. I mean, I've been pushing this at American Heart Association meetings, and of course I get all the pushback of like, well, that'll be a great study to do. And then I'm like, and in 30 years we'll have the answer that this works. And I just think this is, hopefully I know Diane's putting together a bunch, we're contributing a bunch of the Titin variants to it, so Diane Fatkin is organizing to just really gather information on all the families we can get our hands on who have Titin truncating variants, and then hopefully we can get something out there with that.
that you can use as support to help educate your primary care provider.
Yeah.
Dr. McNally, from your experience, do you have any sort of idea about if there's a carrier, and is it predictive based on the type of variant whether you will have later onset cardiac problem from your experience?
Well, again, if you go to that 2015 Roberts paper, that would suggest that, again, I-band is going to do better than A-band, but I don't think we really have that. This new Circ paper that just came out, which is taking Titin truncating variants and then looking at the Geisinger health record and the Penn biobank, so it's quite a few people that they have. They suggest, that paper actually says it doesn't matter where in Titin your truncating variant is, there's risk all across Titin. And they also suggest that certain racial ethnic groups may actually be a little more protected than others, but I would caution with that because I think the number of non-European ancestry people in their biobank is really, really small to be drawing that conclusion. They actually go out and say like people who are African American who have Titin truncating variants are more protected. And in our experience here in Chicago, where we have a lot of African American patients, we don't believe that's true. So Geisinger is, for those who don't know, Geisinger is Pennsylvania and covers a lot of Western Pennsylvania. So the biobank and their data set is really full of a lot of people from Western Pennsylvania who by and large are European ancestry.
No other questions? So I think to wrap this up, we're going to be watching for these guidelines for care, for diagnosis and care for the management of the cardiac aspects of titinopathy that would be enormously useful for both us as physicians or as myologists or neurologists, and also for the patients to help get the best possible care.
I think, we struggled with this for Duchenne muscular dystrophy for a long time. There were a lot of papers out there that said a lot of different things. And what we organized was just a one-day workshop where we put together a lot of experts in the field. And out of that one day, maybe it was 2-day workshop, we actually drafted a document that was sort of best expert guidance. And probably that's what we need to do right now for Titin truncating variants.
We could do that.
I think you should.
I think
So,
you should, yeah.
and I'll tell you why it happened, because Pat Furlong at PPMD organized it together with NHLBI. And we did it at NHLBI, but PPMD helped support it. And we put about 20, 25 people in the room, and we just hammered it out, and we got it done in 2 days.
Yeah.
That's how we established the guidelines for diagnosis and care for congenital muscular dystrophies and for congenital myopathy.
So I think that would be a really good action item, and I can put you in touch with, like, John Kaltman organized it at NHLBI, and I bet you he'd be willing to do it.
It's on my list.
Yeah.
Excellent. Well, thank you
I just
very much.